a day, as I said. There's BD twice a day, CDS 3 times a day, QDS 4 times a day. PRN is as required, so most of your pain medications will be PRN prescriptions. ABX is for antibiotics. This one I'm not quite sure if I got it right. P for X. Sometimes I've seen it as X, so it stands for prescription. NBM is nil by mouth, so we have VTE, which is venous thromboembolism. The different drug routes that are used, PO is for us, so oral. SC is subcutaneous, IV, intravenous. Probably know most of these things. I'm not just going to bore you reading them all out. Yeah, these are some of the things that you will encounter, some of the abbreviations. So reviewing drug charts. So when a patient comes into hospital, one of the most important things that we do as doctors for them is to review their medications. So on admission, so when do we need to review drug charts? First of all, when they come into hospital. The other time is whenever there's a change in their status or medications, new medications have been prescribed. There's an improvement or deterioration when they're post-op, pre-op. All of these times are, or really every single time you review a patient, it requires even a 30-second just quick run through of their medications, because like we saw in the case I just read out, if you just go in there prescribing just because the nurse told you to do so, you might just prescribe a medication that is contraindicated in this particular patient. The last is on discharge. So on discharge, the patient has to be reviewed. So what we do when a patient comes in the hospital regarding their medication, we prescribe their regular meds. There are some very important medications that should not be missed. So that's why every patient needs their medications reviewed before, during admission, so they don't miss very important medications. And we also do it to suspend medications as appropriate. So if a patient looks like they'll be needing surgery, then you might want to suspend their anticoagulation medications or antidiabetic or diabetic medications, and short-term insulin for patients who are nil by mouth and not eating. You need to prescribe appropriate medications as indicated. So based on why the patients come into hospital, whether it's antibiotics or IV fluids, analgesia, or whatever they need on admission should be prescribed during drug chart reviews. We also need to check for drug interactions. So some trusts, like my trust, we have what we call bundles and protocols that we prescribe to some patients. So there can be some medications in a particular protocol that might be contraindicated in some patients, just because maybe they're taking another medication that might interact with that medication. So that's why we need to review the drug. Allergy is very, very important. Every patient coming to hospital needs the allergy status reviewed, just so that.
Hi, sorry to interrupt you, Dr. Abel.
Yeah.
I had a few messages about the sound.
Okay, yeah, I just saw that now.
Yeah.
Can you hear me better, or is it still the same?
Guys, what do you think? Can you guys in the chat please message as well? Yeah, there's some background.
Is it still the same or better?
There's still an echo and a little bit of background noise as well. But this,
I'm in a closed room, so that might be
Okay.
I could, what I could do is take the headphones off and see if that helps.
Yeah, you could try that. Perhaps that would help.
Yeah. How is it now?
That seems better for me. Everyone
Okay.
else? Yeah, I think we'll go with that. It sounds better on my end. I think the chat will catch up.
Okay, sorry.
It's all right.
Okay, so yeah, allergy status needs to be reviewed so that medications are not prescribed for a patient who's allergic to them. Okay, so sorry, looks like presentation is frozen. Okay. Yeah, it's fine. Okay, so this is an example of a paper prescription. Sometimes the prescribing systems can malfunction, in which case we have to revert to paper prescriptions, okay? So this is an example of a paper drug chart that you can find for patients coming into hospital. So it has all of these details. I'm not going to go over every single one of them, but the important things to see on this is the allergy status has to be there. And it's also important to say what reaction they got to the medication, because sometimes it's just sensitivity to a particular medication, not necessarily an allergy. So that's why it's important to ask the patient what their reaction. If it was just nausea or diarrhea, then it's more sensitivity than an allergic reaction. And VTE prophylaxis is also important because some patients would need to be put on anticoagulation medication when they come into hospital. Others might not need to be put on because they are more prone to bleeding than normal. All right, so that's why it's important to review their VTE, to do a VTE assessment for these patients. Okay, and then so in cases where the electronic systems are down and you do need to use these paper prescriptions, for example, in the ED, so in the ED, they usually prescribe medications that are given just once, okay? So one-off medication like analgesia or anti-sickness medications, and these can be just in this column, so once only drugs, right? You also need to put your name, time, sign, put your bleep down, and all of the details that are necessary for that. Okay, and another page of that same prescription. This is an example of a prescription I took off of my former, my current trust actually. So this is what they used before the electronic prescription. And yes, oxygen is also a drug and needs to be prescribed if it is necessary for a patient. You can see the different targets for oxygen, oxygen saturation for every patient. So a normal patient would probably fall under the 94 to 98% saturation. But some patients who have, for example, COPD, don't fall under this first category because they've chronically been hypoxemic and the saturation is lower than the norm. And giving this patient too much oxygen could actually be harmful. Okay, so that's why oxygen needs to be prescribed. You may not, usually on the ward, the nurses are able to titrate the amount of oxygen given to achieve a particular saturation range for the patient. So it could be 1 liter for one patient or 2 liters for another patient for them to achieve a particular oxygen saturation level. But yeah, it is necessary. You need to prescribe it. So there are different routes for oxygen prescribing. So there is we could use nasal cannulas, or we could use masks, and we could use high flow as well. So it depends on the patient's current oxygen requirement. So that's the important point, is that oxygen is a drug and needs to be prescribed if the patient needs it. So you can't just assume that it would somehow systematically be prescribed. Okay. So insulin prescription. Like I said, when a patient comes into hospital, if the patient is diabetic and they are on long-term insulin, so we have short, intermediate, or long-acting insulins. And so long-acting insulin should never be suspended during admissions. That's very important. Short and intermediate acting insulins can be stopped, and the patient will have a valvular infusion instead. Okay, so that's quite an important bit of information to take from this teaching. So never suspend long-acting insulins. Otherwise, the next day or a week later, or maybe months later, you get an email from the diabetic nurses why this happened. This has happened to me once, so speaking from experience. So insulin prescription for most trusts, it is done via paper cards. So you need to fill it out. You need to prescribe on BPMA, but you also need to prescribe on the paper card. So the paper card has the particular doses of insulin and the times that they're given. So I'll show us an example of that. This is an example of an insulin chart. So it tells you the important things is the name of the insulin, so the brand name, the dosage, so it could, if it's short acting, so they're giving at meal times. Basal insulin, these are long acting insulins that are given once a day, usually in the evening. So those should never be omitted. So you need to prescribe them when the patient comes into hospital so they don't miss it. Okay. And for a normal patient that is not being starved, you need to prescribe the short-acting insulins on this paper chart. So dosage, time, unit, and you need to put your signature in there as well. Important thing about insulin prescribing is that we no longer put U at the end. So if you're giving 6 units of Novorapid or Actrapid, you don't put 6U or 6 units or something. You just put the number on there. This is because there have been multiple occasions where people have written 6U and someone thought it was 64 or 60 units of insulin and have prescribed the wrong amount of insulin. So that's another important point. So insulin prescriptions don't include units anymore. Okay. So that's just an example of what the paper chart looks like. Your trust will have it, so you will have an opportunity to go through it in detail. Right? It's advisable to do this before you actually have to prescribe insulin or any other drug, for example, for that matter. Another thing that you will be doing probably most of the time as well, especially if you work in a surgical ward, is analgesia. So you will be prescribing a lot of painkillers for patients. It's important to know what your drug's guidelines are for analgesia. It's a World Health Organization analgesic ladder where you go from non-opioids to NSAIDs to opioids to combining them and all of that. So combining them and all of that. So most trusts again have guidelines. I'm not just going into too much detail in this, just because you will encounter them, and you will have the opportunity to see what your trust recommends. So the EPMA also has analgesic bundles as well. So you can have a combination of all of these pain meds, and so you wouldn't have too much problem with prescribing them. Okay. And this presentation will be available to you, so you can go through that picture over there. The TTOs are also known as to take out. So these are medications to give to patients on discharge. So the idea is most patients come into hospital sick, right? And they're going home. They probably wouldn't be able to go to a pharmacy or get to their GP on time to get a refill of their medication. So we kind of restock their medications so they're not running out anytime soon. So that's one reason. The other reason is whatever medications we prescribe to them while they're in hospital and we think they need them outside of hospital, we need to make it available to them. Pharmacy and nurses are really, really big on this, right? So the best way to get the nurses to love you is to prescribe the TTOs early enough. So usually what happens is if you have a patient that is due to go home the next day or maybe in 2 days, and there probably won't be that much change in their medication, it's ideal to prescribe their take-home medications the day before, so pharmacy can have time to prepare them ahead of discharge. CD script. So CD stands for controlled drugs. So these are drugs that have high potency for dependency and addiction. So you need to, for these drugs, you need to sign on the prescription charts. So, for example, in my trust, you would prescribe them on EPMA, and then you will print them out instead of just saving and sending to pharmacy electronically. You will print them out and you will sign them, write the names of the drugs in ink, and you would put a date and the dosage and all of that. So this is just to make sure that these drugs are not just prescribed without the clinicians thinking about them, okay, because they can be dangerous to. Okay, so control drugs, like I said, examples of these are morphine, tramadol, morphine, oxycodone, barbiturates, fentanyl, gabapentin, pregabalin, buprenorphine, and and so on. Usually, so for my trust, if there is a CD drug on the prescription, there will be a prompt on there, or pharmacy would give me a call to say, oh, there's a controlled drug on your prescription and you need to print it out and sign it. So that's another thing to be cautious about. Fluid prescriptions. Another important thing that you will be doing quite commonly. So we have replacement fluids and we have maintenance fluids. So replacement fluids are usually of short duration. They can be boluses. So a patient is hypotensive and you need to do a fluid challenge. You give them 250 mils of Heartland or 0.9% sodium chloride to see how they respond to that. So these are replacement fluids. And if the patient is also hypertensive from hemorrhage as well, so you want to replace it quickly. So the main difference is, well, these are short duration IV infusions, while maintenance fluids are more of longer duration, so 4 hours to 6 hours to 8 hours, 10 hours, depending on the patient's needs. Examples of fluids that we prescribe are Hartmann's solution, 0.9% sodium chloride, plasma lye, 5% glucose, 40 millimole per liter KCl, iron infusion. That's in a different category, actually, but yeah, that's another thing that we prescribe. That again needs, at least for my trust, it needs a paper prescription. So you prescribe it on EPMA and on paper as well. So you can see that some of the dangerous sort of drugs are usually prescribed on paper and electronically, so that you pay double attention to them and mistakes are easily spotted. Because if you prescribe a drug on EPMA and you make a mistake there, the chances of someone picking that up are not as much as if you prescribe it on there, make a mistake, and then you prescribe it correctly on a paper prescription, right? So someone can easily pick up on that and so on. The difference is in the contents of these solutions. So Hartmann, the most the electrolyte with the highest concentration would be sodium and chlorine. Also, same thing as sodium chloride as well. Hartmann's is more physiological than sodium chloride. So most people prefer to prescribe Hartmann's for maintenance than sodium chloride. Also, it also depends on which trust you're in. So my former trust was more a sodium chloride trust than a Hartmann's solution trust. But my current trust is more Hartmann's than sodium chloride. The important thing to note about sodium chloride is that the patient can go into hypochloremic acidosis because, again, sodium chloride solution has quite a significant amount of sodium chloride that can be harmful to the patient if prescribed in enormous amounts, like 3 liters or 4 liters or something like that. Okay, just trying to make sure I don't talk too much and run out of time. Blood products are also something that you would be prescribing as well. So you can be prescribing packed red blood cells or fresh frozen plasma or platelets or cryoprecipitate. Or by far the most common thing would be packed red blood cells. So that's something to be aware of. Again, I think there's a paper prescription aspect to this. Actually, yeah, there's no electronic, at least in my trust, there's no electronic part of red blood cell prescribing. So you need to phone pharmacy for it, fill out a prescription, and it would be sent. And then there's the rapid transfusion protocol for major hemorrhage, which is beyond the scope of this presentation. Antibiotics, another common thing that you'll be prescribing. So we have IV versus oral antibiotics. Microbiology and pharmacy would always encourage you to consider oral antibiotics first before jumping to IV antibiotics. Of course, they would overrule or override your decision at the end of the day, but they will encourage you to do that just because IV antibiotics, or usually a patient with a cannula would have a longer hospital stay when compared to a patient without a cannula, because it would be easier to send them home than a patient with an IV medication. So consider oral before IV. Of course, if the patient is quite septic and you're worried about them, you would go with IV antibiotics, at least for the first 2 to 3 days, and see how they respond to that. Then you would switch them to oral antibiotics. So IV to oral switch. So there's broad spectrum versus narrow spectrum antibiotics. Again, if a patient comes in septic and you're not sure exactly what's causing it, you would send, if you suspect a UTI, you will send a urine sample and then start them on broad spectrum antibiotics. But then, again, various trusts have antibiotic policies. So refer to your trust policy for antibiotics, because there are common bugs for different infections. So prescribing is also based on that. So again, refer to your trust guideline for that, but on a basic level. So you would give a broad spectrum antibiotic if you're not sure what the bug is, and then you would wait for the microbiology MCNS to come back, and then you would either change or maintain the same antibiotic based on the results of that. So indication, it can be suspected or confirmed infection. So for antibiotics, electronic prescribing sometimes comes with indications. So some trusts are trying to incorporate that into their prescribing systems, so that pharmacy can know why they're prescribing it, and all the doctors can also know why you've prescribed a medication. I think that's really important. So duration is also important. Sometimes you prescribe, again, on EPMA, there is a part where you can put the duration of an antibiotic. Most people just prescribe and leave it at that. The problem with that is that some patients can go 10 days, 12 days on antibiotics that they probably no longer need, just because someone has not cared enough to put a stop date on the antibiotic. So that's why it's important. So even if you don't know how long they're going to be on antibiotics, it's good practice to put either 5 or 7 days as a rule of thumb, just to keep patients from staying too long unnecessarily on antibiotics. So 5 or 7 is the usual time for antibiotics. It's important to also consider that duration is based on combined time on antibiotics. So you add when they were on orals plus when they were on IV antibiotics. Okay. Antibiotic resistance. So again, it's advisable to exercise caution with antibiotics. Don't prescribe unless the patient really needs them, right? Antibiotic resistance is a thing in the NHS. So do your best to help the situation by not unnecessarily prescribing antibiotics. And again, if you're unsure, trust guidelines will help you, or your local microbiology team can help you with that. So anticipatory meds. These are medications that we prescribe to patients who are palliative or end of life. They're based on symptom control, right? And they're usually subcutaneously administered. So again, when a patient is nearing the end of their life, one of the things that you want to control is pain. So we give subcut morphine for that. Nausea is another thing. We give haloperidol for that. Respiratory secretions and bowel colics are also a thing. And we give iosine, hydrobromide for that. And some patients can also get quite agitated, and so we give midazolam for that. Again, local guidelines are in place for that. So some trusts have bundles, protocols for that on electronic prescribing. So you can find them and prescribe them, or consult your local palliative care team for that. There are some useful apps that can help you in your prescribing. So BNF is one of them. There's the adult BNF, and then there's the pediatric BNF. But if you just go on Google and type BNF, NICE, I think, this will pop up, or you can download the app on your phone as well. MicroGuide helps you in antibiotic prescribing. MDCalc, as I saw in the previous teaching as well, the previous teacher was also using that. So that's another thing they could use. NICE guidelines, and again, your trust guidelines. Actually, it should be trust guidelines and then NICE guidelines, because you would go with the trust guidelines when there is any discrepancy in that. I just want to make sure I haven't skipped any slide. Hold on a minute. I think there's one. Okay, I'm just going to talk about warfarin prescription. So warfarin is another drug that combines a paper prescription with an electronic prescription. But this is not in all trusts. So my current trust does not use the paper prescription, but my former trust used it. So it's important to get used to it as well. And again, warfarin is based on INR. So think about bridging warfarin for patients who've been off warfarin. They need to be bridged with enoxaparin, so low molecular weight heparin for that. And yeah, again, your trust would have guidelines for that. I know I've said a lot about guidelines, but really, they are there to help you. Like I said, pharmacy was not my favorite, pharmacology rather, was not my favorite course in subject in school, but then prescribing is not as bad as pharmacology. Okay, so we go back to the case. 65-year-old female, day 1 post-lap appendectomy. You've been bleeped, the patient feels sick and is in pain, and the nurse wants you to prescribe analgesia and antiemetics. This is a classic, because most nurses would not call you to review the patient. They would just tell you what you need to do. Sometimes it's good, sometimes it's bad, because they might not see the big picture. And if you just prescribe medications from afar without actually reviewing the patient, you might miss something. So in this situation, you would review the patient, make sure that this is not a complication of surgery, okay? And if that's the case, you would review their medications, see what they're on already, because sometimes it's possible they have not been receiving their medications. They might have been prescribed PRN medication, pain medications, instead of regular, right? So that's something you need to look at as well. And some antiemetics are contraindicated in some situations. For example, metoclopramide, you wouldn't give that to a patient who might be in ileus, right? Because that's going to worsen the situation. So the point of this is to take note of the fact that patients, you can't just prescribe medications from afar. You need to, again, especially if you don't know this patient, right? Because you might be on a night shift or a late shift, and you're covering the whole ward, and you don't necessarily know the patients by heart. So if that's the case, then you need to really review the patient, review the drug chart, and then prescribe as indicated. So if this patient is in ileus, which could be the case, then your management would be different from prescribing meds and antiemetics to the patient. Okay. All right. I think I can take questions now, if any, if I have time as well.
Yes, thank you. You can take questions. Does anybody have a question for Dr. Abel? I saw one on the Slido link, but I think you answered it. The only question on here really specific to you is, what resources do you recommend for learning drugs to prescribe? I think you mentioned a few apps.
Yes. So if you go to the BNF, you can search for a condition. You can search for conditions and not just drugs. So you can search for conditions on there. So nausea, vomiting, for example, and it will pop up with some drugs that are prescribed for those. Because all the drugs have indications, right? Dosage and all of that. So if you search for a condition, then the drug will pop up because that condition is under the indication for that surgery. So BNF is a valuable resource for that. And also, part of being a doctor is you learn from experience as well, right? So you, again, trust guidelines will help you a lot. If you search for example, antibiotics, if you go to your intranet and search antibiotics, it will come up with the different recommendations from your trust for those. And then most of the times you would get used to what is prescribed, right, for different conditions as well. So this is not a very straightforward answer, but it's how I've navigated this myself personally.
Okay, thank you. I can't see any other questions specific. Oh,
Well, my email is down there, so if you have any questions.
yeah, okay. There's one question actually. So
Okay.
as you've moved from Prague, are there
Yes.
any resources that you would recommend to better familiarize or prepare ourselves with how work would be in the UK or in the NHS?
Well, conferences like this, I suppose, would be very useful for that. Also, try to get, so most trust, again, arrange teachings and all of that for international medical graduates, just to help them familiarize with what's going on in their trust and in the NHS generally. So there's that. There's also mentorship programs available, again, in some trusts where you are paired with maybe a one-time IMG who knows what life is like moving from Europe to the NHS as well. Otherwise, I would recommend just reading up on some nice guidelines. So whatever you can think about, for example, whatever concerns you have, concrete concerns you have, you can find resources that can help with that. So NICE is one of them. And there are some platforms as well for international medical graduates on Facebook and all of that. And also having contacts. I think that's the most important part. Having someone on ground that you have personal contact with can help you a lot in that aspect. So it might not necessarily be a document online that you can just find that answers all the questions, but it's usually a mix of getting information from here and there. So yeah, I think